like Dr. Maribeth Maritim, who's a key infectious disease specialist who's helped the country navigate COVID-19, the pandemic. So as I said, my name is Dr. Nancy Ngumbao. I am a medical practitioner, medical officer, currently based at the Medical Research Department. And today we'll have several remarks. We'll start with the county representative, Honorable Joseph. Okay, we'll have several representatives who will give us a few of the remarks. And then now we will hear the ECHO journey in Kenya and the IT updates that are there. And we'll see how has ECHO connected us and what are the benefits of these programs and what has happened. And then we'll have an official launch where we'll celebrate ECHO and have keynote speakers. Right now, I'd like to hand over to Dr. Kenneth Masamaro. Daktari will now be inviting everyone who is making the remarks. Thank you so much. Karibuni sana. We would like to now celebrate ECHO. Thank you so much.
All right, thank you. Thank you very much, Dr. Nancy. And good morning, good afternoon, good evening, everyone. My name is Kenneth Masamaro from CDC Kenya. For us, it's high privilege to welcome all of you once again to this virtual meeting to officially launch the expansion of ECHO, but also to hear the keynote session hosted by the KNH Hub. I want to acknowledge the county governments present, represented by their county executive members, committee members of health, hospital leaders, their staff, representatives and heads of different organizations, all healthcare workers present, ladies and gentlemen. We clearly have a packed agenda. And I want now to call upon a few people to give some remarks just on the process going forward. So first, I want to call upon Honorable Joseph Mbai, if he's on the call. This is a CEC Health for Murang'a County. If he's on the call, and I hope he has been made a panelist.
Dr. Masamaro, I think we'll continue. He's still not on. I can't see him on.
I can see him.
Oh.
Yes, I'm here. Sorry.
Sorry.
I'm here. Sorry for that. Good afternoon, everyone. My name is Joseph Mbai. I am the CEC in charge of health, Murang'a County government, and I'm also the chair of the CEC caucus in the country. And I want to say that I'm delighted to be part of this discussion this afternoon. So I want to thank the team for inviting me so that I can represent the counties. And I must say that I'm also expressing my gratitude because Murang'a County was chosen as one of the centers where a hub will be established by CDC, and say that in the advent of COVID-19, I think we have learned a lot of things up to now. COVID has taught us so many things that we really need to share experiences across the counties. I'm sure most of the counties have had a fair share of infections. In Murang'a County, we have had about 1,200. We've not done very badly, but we've lost a few people as well. And we have experiences in terms of management, in terms of control, in terms of prevention, and we would really love to be sharing some of these experiences. So I know the hub will go a long way even to help us do our CMEs so that we can be able to disseminate information timely that really needs to go a long way in helping our patients. And without much ado, I just want to say that as the county governments, we really appreciate and we are committed to continuously serve and deliver the mandate as stipulated in the devolution systems. Over to you, Chair, and thank you very much.
All right, thank you very much, Honorable Mbai, for those excellent remarks. I will now move to Dr. Mark Guterres, who's the CDC Kenya Country Director. Over to you, Mark.
Thank you very much, Kenneth. We are really pleased to be here today with all of you. I see almost, now we are already over 660 participants who have joined this call. That's pretty remarkable. I would like to thank all the stakeholders that are present, Ministry of Health first, our county government representatives, the CECs that are present here on the call, the University of New Mexico Echo Institute represented by Professor Bruce Truminger, dear colleague and friend, the CDC Kenya colleagues that are on this call, and all the work that Dr. Kenneth Masamaro has done for this program. Our colleagues also in Jupaigo who have been helping set up the county hubs. Our University of Nairobi colleagues, we work together on many different areas, and this is really a critical one. University of Nairobi has so much capability to do the trainings and to set up this hub. And then, ladies and gentlemen, everyone who's part of this first call and launch of the ECHO platform. It's really a momentous occasion for us. There's 17 counties present here, and this will allow us really to share knowledge virtually and to build communities of practice with the plans to expand even beyond these 17 counties. We're also, talking with our colleagues in other countries in the region on how we might be able to collaborate more closely within this region of East Africa. CDC, as I think you all know, we are first and foremost a science-based technical organization. Although we also do provide some funds for certain activities, but we are not a donor in the traditional sense. We are a science-based organization. In the HIV response through PEPFAR, since 2016, we have provided also a platform for ECHO. So that has been used in the past 5 years with a hub at the NASCOP. But we felt that University of Nairobi has additional expertise to offer, particularly now that we are focusing also on COVID-19 and other emerging infections. So to help us with emergency preparedness and operations, in outbreak tracking, in laboratory support, how to best protect our healthcare workers. So IPC, infection prevention and control, really critical areas. And CDC has provided direct support also to the county EOCs in these same 16 counties. In addition, we provide a substantial amount of support to the national EOC. But also at the county level, we have at least one of our CDC technical staff that is directly working with each of these county EOCs. And we've also provided to each of the sites some funding for their EOC, and now also funding through the ECHO program, so that each site has the equipment for being a hub. What it all means, well, providers and healthcare workers can virtually interact now, share knowledge, including discussing some of the more difficult cases. And sharing this expertise is, truly, I think, a game changer. It has worked really well also in hepatitis C care and treatment. Bruce was part of that program. to originally expand hepatitis C treatment to some of the rural communities in the US, particularly Native American or American Indian and Native Alaskan communities, who are very affected also by hepatitis C viral infection. And then that program went from the US to now, I think, over 50 countries in the world, where ECHO is providing really the expertise to treat patients living with hepatitis C. And from that, it has expanded further. And I think Bruce will talk more about that. It also allows us to have decreased transaction costs. Instead of doing very expensive workshops where people have to travel and then stay at hotels, and that's often quite expensive. Now it is possible to all interact with larger groups even, and being able to address some of the most pertinent public health challenges that we face. Let me say also in Swahili, hatuwezi kujitenga kama kisiwa. So we don't even have to be living on an island anymore. We don't have to be isolated in one hospital. We can communicate with experts from a very large area and really throughout the country and even beyond. So I mentioned that we are trying to expand this also to build these regional communities of practice. We are in collaboration now with Uganda, Rwanda, Tanzania, Ethiopia, South Sudan. And so that will, I think, provide great opportunities for hearing from experts within the region. Finally, I would like to thank everyone, Asanteni Sana, thank everyone for collaborating on this and being interested in contributing to this. And especially now for this first ECHO session through the Kenyatta National Hospital, we thank our colleagues at the University of Nairobi for all their efforts. They will give the first session talking about safety concerns on vaccinating individuals with comorbidities. So special thanks to everyone, all protocol observed. I hope I didn't forget anyone. It's really, you're all really important for this session. So with that, I will put myself on mute now and turn it over to, I think, Professor Struminger.
Thank you, Mark, and good afternoon, everyone. It's really super exciting to be joining you from New Mexico and to see, I just saw the number of participants pass the 900 mark, which is truly extraordinary. As Mark said, the goal here is to create a learning and clinical knowledge sharing network. And today we've already created the largest network in Africa that I'm aware of, and connecting colleagues across all of Kenya. So I just want to thank colleagues at the Ministry of Health of Kenya, at Nairobi University, at the US CDC in Kenya. Mark Bolteris and Kenneth Masamaro have been key catalysts to this effort, as well as our colleagues at JPIGO helping support this, and our team at the University of New Mexico. And in particular, to thank everyone who's tuned in today, the 900 participants, because this is all about you. And Project ECHO is a workforce development and education initiative, and it's all about continuing professional development. And I'm thrilled to see that this series is going to be offering continuing professional development credits to all the clinical staff participating. But we'll hear a little later from Kenneth about the journey of ECHO in Kenya, which started over 5 years ago and has been already an amazing journey involving the development of multiple programs for HIV, as Mark mentioned, for tuberculosis, for autism, for antimicrobial resistance, laboratory strengthening, for primary care, through colleagues at Moore University. So there are already multiple programs, but But this initiative really exponentially is expanding the network across Kenya, as Mark mentioned, to 17 counties, and in the future to more, to help create a truly national network that will allow not only support to the COVID-19 response, which is needed immediately, but in the future will lay the groundwork for new public health and clinical learning programs as the need arises, so that Kenya will have its own national and county level networks to provide continuing professional development to clinicians across Kenya as the needs arise. So I'll be back a little later to talk more about the global ECHO context, and so you have some sense of how this amazing Kenya initiative fits into the African and global ECHO networks. But truly, this is amazing. Actually, we're almost at 1,000 participants. Again, also, I want to thank the Merck Foundation, which has been supporting this initiative, helping purchase equipment and support in other ways. But most importantly, thanks to all of you for participating today. And I'm really looking forward to hearing the cases from our Kenyatta Hospital colleagues. With that, Kenneth, back to you. Kenneth, you're on mute.
Yes, thank you very much, Professor Bruce, for those excellent remarks. I want to turn it over to Dr. Steve Mtwiwa, who is the country director for JPIGO, to give some remarks. Thank you.
Yeah, thanks so much, Dr. Kenneth, and all my colleagues. I want to appreciate the collaboration we have had with the University of New Mexico, led by Professor Bruce, and CDC Kenya, led by Dr. Mark, and of course, Dr. Kenneth being like the engine of the whole operation, and the county departments of health. So I totally appreciate all the county leaders that are represented here and all the participants. My name is Dr. Mtwiwa Stephen. I'm the country director for JPIGO, and JPIGO is an affiliate of Johns Hopkins University. We operate in different countries in the globe, and our main mission is to work with local governments and communities to ensure that mothers, children, and their families have access to quality services through building capacity of providers. In Kenya, we have worked for close to 50 years now in different areas at all the levels of the health system, mainly in the HIV and maternal health, child health space. And therefore, in the era of the COVID pandemic, we have been supporting the government and the county at different levels with funding from different donors. With USAID, we have supported the Emergency Operations Center, operationalized their strategic plan. We were doing distribution of the 200 ventilators in the different counties, and we have been supporting development of training material. And we are now getting to the support for the oxygen ecosystem. So when this collaboration came with the University of New Mexico, CDC Kenya, University of Nairobi, we were very excited to be a part of this, especially because it builds the capacity of the facilities, the providers, and the counties to be able to exchange knowledge and improve the service provision, at facility level. Our main role as JPIGO was mainly to set up the hubs at the facility level. So we went out to all the 17 facilities, 16 counties plus Kenyatta National Hospital. We were looking first to make sure there is connectivity, so we ensure there is sufficient internet access. There are few counties that we had to link to the national fiber network. That was Kitui, Narok, Kiambu, and Kerugoya. And for the others, all the apps, we were able to set up a 65-inch smart TV. We were able to make sure they have the latest model computer desktop, a 360-degree camera, and a Bluetooth speaker for these, and then USB to ensure that there is a proper backup. And then each one of them also has a Wi-Fi hotspot to backstop in case the internet has gone down. And in terms of the capacity building, we also ensure the ICT officers are oriented and trained on this system. And we are going to continue providing that tier to ensure the hubs are working and there is that sufficient capacity to be able to continue operationalizing the hubs and even reaching the lower level facilities. So we are very excited and very happy for the support we got at the county level, at the introduction and inception level, and we still look forward to working together in terms of knowledge dissemination and everything. So thanks a lot, and I want to wish every participant all the best as we experience how these hubs are working. Back to you, Kenneth.
Yeah, thank you, Dr. Steve, for those excellent remarks. I now want to turn it to Dr. Jared Mecha of the University of Nairobi to give some remarks.
Yeah, good afternoon, good morning, good evening, colleagues, the county executive committee members that are present here, our other county colleagues that have tuned in, the CDC country director together with CDC colleagues that are here, colleagues from the University of New Mexico, Japaigo, colleagues from ECHO India. And at this point, I really would like that we spare a thought for our colleagues in India and really pray that they will be spared the worst of this pandemic. My colleagues from the University of Nairobi, colleagues from Kenyatta National Hospital, and healthcare, frontline healthcare workers from across the country. It is indeed a great day for this country, and I do share the sentiments of Prof. Bruce. We have 1K plus already tuned in to this launch meeting. I think we are ushering in a new era of medical clinical education, and a new era of collaboration across the levels of healthcare, whether you are talking about community healthcare, primary healthcare, secondary, tertiary, you're talking about specialist care, primary care, and all those. I will just make 2 points. One point is obviously to thank the ECHO fraternity, University of New Mexico, for together with the funders, for really thinking of our country, Kenya, as one of those that would benefit from this revolutionary technology. To you, thank you very much. I would like to thank colleagues from Japaigo with whom we have worked very, very closely under the guidance and leadership of CDC and Dr. Masamaro to ensure that the hubs are set up really within about I would say no more than 90 days of active work to bring this to fruition. The second thing I would like to say that through the ages, pandemics have shaped or changed the course of history. And as uncomfortable as it is that we are in this current pandemic, we think that it will change the course of history. And what we are witnessing today is part of what will happen, in that those that were present during those pandemics used the tools that they had to alter the course of history. The two great tools we have during this era and during this pandemic is really digital technology and genomics. And we think that those two will change the course of history, and it will make the world better. And we want to appreciate those who are already looking into this digital resource that we have to change the way we care for patients, the way we train healthcare workers, and the way we collaborate with regards to ensuring the best possible clinical and medical and population health outcomes. The final thing I would really like to say is obviously appreciate the work that we have done through the support of CDC. During this pandemic, we have leveraged the extensive investments of the CDC, for example, in lab systems to turn around quickly, testing for COVID. We are aware of the extensive health systems investments that have been used to ensure that we are able to quickly, respond to this pandemic. And for us at the University of Nairobi, we want to commit ourselves to ensuring that the content, the capacity building is made available to ensure that these technology and this platform, the ECHO platform, truly benefits both clinical outcomes and also population health across this country, and obviously across the region when the time comes. So thank you so much. Also looking forward to the excellent discussions that will be coming after this. Asante sana. Thank you for having us.
Great. So thank you, Dr. Meche, for those excellent remarks. And I believe this is a nice segue to talk a little bit about, very briefly, about the work that we have done, including the journey that we started. So I will briefly share my screen so that we just provide that context. Great. So once again, is really to appreciate everybody who has been on this journey. This is a journey that started way back in 2016. And you will see on the picture on the top left here, this is when we set up the first Echo super hub located at the the NASCOP complex. Of course, Echo has grown in leaps and bounds, and we are now talking about 17 counties having physical hubs and many other spokes with a plan to expand even regionally. So the background is that Echo is really a platform, a video conferencing platform to share knowledge. We know that knowledge, there's asymmetry in knowledge, especially in healthcare. We know that there are underserved regions and communities. And really the aim of this platform is to connect providers so that we are able to democratize medical knowledge. We know that individuals and patients seek specialist care, but we do not have enough specialists or enough providers to sort them out. So the idea was premised on the fact that we need to train those primary care providers and physicians on specialist knowledge. So having a way through technology to connect them together so that patients and recipients of care get the right care in the right place at the right time. We know that this model is lifelong and it generally increases the capacity of the workforce through these hubs and spokes model. How it works is that we use technology to leverage those scarce resources of providers in remote areas having to incur costs in terms of coming to be trained by other providers, and here we're talking about specialists. And so we are bridging that gap with using technology. And this has even become more pronounced with the COVID-19 season, where we actually had to go virtually in how we share knowledge. The vision began back in 2003 and started, and this started as part of hepatitis care, as was mentioned earlier. The founder was Dr. Sanjeev Arora, who really started this video conferencing facility in New Mexico, and then which spread around the United States and has now, as of December 2020, has been spread around 40 countries around the globe with more than 800 learning networks. For us, as I said before, the journey began in 2016, where we set up a national hub at NASCOP. At the time, we engaged the Ministry of Health, NASCOP, of course, and the implementing partner at the time was ICAP. So we came together, we did site assessments, and we set up a national hub, as well as a regional hub in Western Kenya. We held the first Echo clinical session in November 2016. And throughout the period, we have used the platform for many engaging CMEs, knowledge sharing best practices. And in fact, in 2018, the platform was actually used to disseminate information, especially related to dolutegravir concerns in pregnancy in April 2018, as well as to disseminate the 2018 ART guidelines. In 2020, we use a platform to train a number of providers on IPC related to COVID. We then came up with a plan to expand, of course, with the generous donation of New Mexico, University of New Mexico, and working with JPAGO and University of Nairobi, expanded to 17 counties, so 16 counties plus Kenyatta National Hospital. Of note here is that in November 2020, we did a training of trainers just on the general aspects of COVID-19. We were able to train 100 of them, and this was courtesy of Brown University and of course the ECHO Institute through the University of New Mexico. This training has then cascaded to sensitizing other providers. In terms of impact, this was data shared after the dissemination of the ART 2018 guidelines. And basically what they did was they did a cost benefit analysis. And they compared costs of using the traditional didactic trainings compared to the cost of using this technology. And this was mainly in the realm of the HIV echo. What they found out was that the cost of using traditional didactic approach was about $820 compared to just $20, when you remove the transactional cost and when you use the HIV echo model. The program then expanded beyond HIV and went to lab. Lab was able to set up their communities, lab virtual communities of practice, which has also then expanded to the region as well. In terms of our current scope, we working with the University of New Mexico, University of Nairobi, JPIAGO, we set up 17 hubs in 17 counties, with the one hub at the Kenyatta National Hospital. And the plan is to continue and set up, additional physical hubs in the rest of the counties, and just to appreciate all the work that has gone into this. Slides are not moving. In terms of the future, really is first want to complete the setup in the rest of the counties. We really want these networks to form communities of practice. I know we will leverage on the strength so far with the work that Kenyatta National Hospital has done with the weekly webinars. And now through ECHO, really connect to counties even better. But beyond that, we intend to collaborate with other regional countries. Dr. Mark Gutierrez have talked about a few of the countries that we want to collaborate with: Ethiopia, Uganda, Tanzania, Rwanda, South Sudan, and perhaps Somalia. We want to form what you're calling an East African regional network. And this is, a few other countries have also coalesced together to form their own regional networks. So we have a South African regional network and a West African regional network. And you can see how to even collaborate between these different networks, as it were. So really, in terms of the context and the summary is that, it has been a journey since 2016. We have seen impact in terms of just the knowledge sharing of this platform. We hope that it will make meaningful change in terms of knowledge sharing in the counties and even as we expand to all the counties and in the region. I want to end by sharing a quote that knowledge is like money. To be of value, then it must circulate, and in circulating, it can increase in quantity and hopefully in value. And we believe, medical knowledge or knowledge in public health problems and challenges are better when it's circulating amongst providers. So let me stop there. And of course, we are acknowledging, and we've already acknowledged all these organizations. First, the facility leadership and staff, Ministry of Health, University of New Mexico, CDC, the county governments represented so far, Kenyatta National Hospital, University of Nairobi, JPIAGO, and Brown University, who played a pivotal role in the COVID-19 training of trainers. So allow me to stop there and then invite ECHO India to give us some updates on IT, which is quite important in terms of establishing the networks and also maintaining the ECHO network. So over to ECHO India, Dr. Karan.
Yeah, hi, good day, everyone. I'm Karan. I lead the replication team here at ECHO India. So our replication team is supporting Dr. Bruce and his team as we support the expansion of the ECHO network in Africa. In terms of the kind of support that we provide, so we have been providing technical assistance to ECHO programs like this one. In terms of the launch of the programs, we do provide training both for IT support and on other aspects of the ECHO model. And for some of the programs, we provide direct IT support as well as support on things like data management and reporting. And as we move forward, we are happy to provide that support as this network expands as well to the other hubs. And I just like to take a moment to thank all of the stakeholders, the Merck Foundation, Ministry of Health and the local governments as well, JPIGO, CDC, and of course Project ECHO in the US. So the India team is there to provide support, whether it's support on the IT aspect in terms of equipment or any kind of training that's needed, or in the case of holding the larger webinars. Those are all areas where the team is happy to provide support and technical assistance. So thank you all for being a part of this. I think it's a great first session, and we look forward to continuing to be able to support you. Thank you.
All right, thank you, Dr. Karan, for those remarks. So I think in the interest of time, we want to hand it back to Professor Bruce to give us some words of wisdom to officially launch the program.
Thank you. Thank you, Kenneth. And thanks again to everyone for joining today. I know the main event we're waiting for is to hear the cases and the discussion from our colleagues at Kenyatta Hospital. So I don't want to take too much time, but I do want to share a little bit of history and context about ECHO. I'm going to take about 10 minutes. Hopefully, Kenneth, that's okay. You've already heard from Kenneth about the ECHO journey in Kenya, and I just want to give a little background on the bigger ECHO journey globally. And as I said at the beginning, Project ECHO is a workforce development and collaboration initiative started at the University of New Mexico 15 years ago. But now there are partners, almost 500 partners in over 45 countries, adapting this virtual community of practice and collaboration method to achieve public health goals around the world. In my title, I mentioned here promoting health equity. For me, this is one of the most important aspects. We are trying to achieve health equity by democratizing knowledge, public health knowledge, medical knowledge, so that patients around the world can get the right care in where they live, ideally, without having to travel. And ECHO is part of the solution by creating networks that can move knowledge and experience to where it's needed, as you're doing today. And it's truly remarkable to see that over 1,000 staff, clinical staff and public health staff across Kenya are joining today. This is the largest ECHO session by far of any in Africa so far. So it's truly remarkable and historic. I'm just showing a screenshot of the first ECHO program in Africa. It was in Namibia, launched over 5 years ago. It's still going strong. It's expanded. The programs in in Namibia were a pilot to see if this virtual education approach would work. In Africa, it worked beautifully, and it's expanded to many countries across Africa. The first ECHO program in Kenya actually was the second program in Africa, and it was really, it was an MDR TB ECHO program. It launched in August 2016, and it was driven by Dr. Maureen Kimenyi, who was up until recently the National TB Program Director. At the time, she was the Deputy Director and head of the MDR program. And she launched this program connecting medical officers across Kenya using their tablets, and she was just using her laptop, no fancy equipment. And that TB ECHO program continues to today, has expanded to a pediatric TB program, a TB Data for Action program, and has really been a also remarkable effort. As I said, the goal of ECHO is to democratize medical knowledge to help improve access to best practice care for underserved people all over the world, and doing that through partnerships like this one with the Ministry of Health in Kenya, with Kenya National Hospital and CDC Kenya and JPIGO and all of you who are participating. The model, just quickly, is to use the same technology we're using to come together today to really amplify the voices and empower the agency of local experts. Today, it'll be experts at Kenyatta National Hospital who are going to share their knowledge with over 1,000 of you across Kenya today. And you're gonna see them talking about some cases. So the ECHO model is a case-based learning methodology where real cases are presented and discussed so that solutions and better care can be provided by local clinicians. Sharing best practices is also one of the components of the model to reinforce evidence-based clinical guidelines, to improve outcomes by reducing variation in processes of care. It's usually done through a brief didactic. And then there's always some element of monitoring and evaluation to promote continuous quality improvement. And today I know there will be continuing professional development credits offered. Ideally, there often will be a post-session survey to get your feedback on how the session went so that the leaders can improve the sessions continuously. Today, when we have 1,000 people joining, we are often using webinars and more of a webinar format, but we are going to try and make this as interactive as possible. The idea with this new series of 16 or 17 new networks is that over time, this program will decentralize to the county level, and there will be county level learning communities and networks where everyone will see everyone and be very interactive. These will be truly learning communities where everyone will learn together and get to know each other in professional learning networks. This is the goal of what we're trying to get at. And as the decentralization of this program happens, hopefully we will see more and more interactive sharing of knowledge and experience in all directions, peer-to-peer, expert to novice, novice to expert. This is an all teach, all learn methodology, supporting collaborative learning, experiential learning. It's a low dose, high frequency learning approach as well. We're trying to connect public health and academic medical centers. We're doing that today. Also the public sector and the private sector to engage all components of the healthcare system. Everyone can be invited, and clearly many have responded to the invitation today. Also, we're really trying to promote interprofessional learning, doctors, nurses, laboratorians, data managers, community health workers, everyone that is involved in providing care. In this case, initially for COVID-19, will be invited to learn together. And this is just summarizing some of the things I've mentioned about why this virtual community of practice methodology is so powerful. We want to keep this need base. So you are all going to be asked what you need to learn about so that the leaders of this program can meet your needs, and to keep this as practical and experiential and collaborative as possible. We're trying to promote a social, professional, non-hierarchical learning network. Quality improvement is certainly a key element of the goals we're trying to achieve. Just saying a few words about the program in the US and globally. In the US, there are partners. We work through many partnerships. There are almost 250 partners, mostly medical schools and nursing schools and departments of health and NGOs in the US, implementing programs in 48 of our 50 states. I'm very involved in a program with our Indian Health Service that has also responded to the COVID-19 epidemic and started an ECHO program serving the whole network of the Indian Health Service starting over a year ago. This is showing a session we had recently with Dr. Tony Fauci at NIH joining us to share his wisdom. This platform allows you to engage people, experts from anywhere, and this was a great session. We also work with our Ministry of Health in the US. This is a series with our ministry focused on monoclonal antibody delivery. Also, sessions have focused on critical care and ventilation management. This is a collaboration which, as you can see, has many professional society partners. So it's a great opportunity to engage professional societies, medical schools, et cetera. Globally, there are now, as I said, programs being implemented by nearly 500 partners in over 45 countries. I mentioned the Namibia program, which started with a small program with 10 hospitals, has grown to over 50 hospitals, every hospital in Namibia, and expanded from HIV to TB to COVID-19 and beyond. There's an article about this experience in Human Resources for Health, which summarized the findings of an evaluation that showed great achievement in learning and in reducing professional isolation. This is an article about how the Namibia program adapted their HIV ECHO to rapidly respond to COVID-19 and used the network to support the national COVID-19 response. Another article in The Lancet by the Namibia team about how they use the ECHO network in Namibia to maintain essential HIV services along the Namibia-Angola border, so to help with border health. Over the last 5 years in Africa, the programs have expanded from HIV to TB to emergency preparedness, antimicrobial resistance, safe surgery, many different topics. Many programs in Africa have expanded the number of programs for different program areas, and particularly through a recent collaboration with WHO Afro, there's been a continental infectious disease surveillance and response initiative that is decentralizing to just about every country in Africa. There are a number of multi-country networks, including an Africa Society of Laboratory Medicine network, an Africa CDC multiple networks, Infection Control Africa, focusing on infection control. That program started 3 years ago and has expanded and been very helpful to the Africa COVID-19 response. ASLM also started as an HIV molecular diagnostic program 3 years ago or 4 years ago, and has rapidly pivoted to support laboratory strengthening for COVID-19 testing, both molecular testing and other diagnostic antigen testing, et cetera. And the Africa CDC has set up regional networks starting 4 years ago that have focused on everything from Ebola to cholera to Rift Valley fever in Kenya and also COVID-19. This is them connecting their Emergency Operations Center at the Africa Union to colleagues in Southern Africa. They've been use this network to address multiple emerging infectious diseases. They use a variety of ways to communicate with each other, Slack, WhatsApp, etc. You may end up using some of those here. There's a One Health network, Africa One Health University network, which I think the University of Nairobi is part of as well, that rapidly started a COVID-19 program with a One Health lens last May, a year ago, and was very helpful. As I said, we've worked with WHO Afro starting over a year ago as the pandemic was just starting, to help engage participants across Africa. In their first session, they engaged over 1,000 participants in almost 60 countries to get just-in-time information across to public health and clinical colleagues across Africa. They've run over 20 or 30 different learning sessions, engaging over 10,000 participants in almost 100 countries. There's a CDC WHO program focused on infection prevention and control, which also has had amazing engagement and been running for over a year now. WHO has helped to disseminate their updated clinical guidelines on HIV and TB and laboratory services across Africa using the ECHO programs that they've started. And they had to pause their IDSR, Infectious Disease Surveillance and Response program, a year ago because of the pandemic, but last fall we were able to help them relaunch it virtually, and they were able to train thousands of surveillance officers across Africa last fall, and they actually have a new cohort that started in February. The last slides I'm going to show are related to the COVID-19 vaccine initiative. We're working with WHO in Geneva to support vaccine managers and healthcare workers globally to have just-in-time, up-to-date information and be able to discuss vaccine delivery and challenges with that. As you can see, this program has engaged colleagues in nearly every country in the world. And it's been truly amazing what we've seen in terms of, expanding these learning networks globally and across the African continent. And today, this program in Kenya is now the largest ECHO program in Africa by far. And I'm really looking forward to seeing how this evolves, and congratulate my colleagues at the Ministry of Health and Nairobi University, at CDC Kenya, JPIGO, our team in India, our team here in New Mexico. And in particular, thanks again for all of you for joining. And now let's get to the real part of this and hear about cases from our colleagues at Kenyatta Hospital. Thank you. Asante sana.
All right, thank you so much, Professor Struminger, for those excellent remarks. I believe we are now launched. The ECHO is really a global movement. I saw a question on the chat, how is this different from using Zoom? And my answer to that is, Zoom is just a software. ECHO is a movement. And it's a model that shares knowledge, using a case-based approach. And with that, I want to thank all the stakeholders, all the presenters, all those who have spoken so far. We now want to go to the main session. We are a little late, but I think it's still fine. And so I want to hand over the program to Dr. Kinobia to facilitate the keynote session. Thank you very much.
Hello, everyone. This is Dr. Karume here. We're from Kenyatta National Hospital, and want to really thank you, everyone, and really congratulate this session that we've had and launching of the ECHO program. We've seen the advantages that it gives, including the safe care and the number and how it can raise capacity in terms of education in our sector and even in Africa. So we really want to thank you to thank the speakers. Right now we are going to another session where we'll have we are going to discuss some matters in regards to COVID. In this first session, I'll welcome Dr. Dorothy Ewak. She is an assistant chief pharmacist at Kenyatta National Hospital with keen interest in pharmacovigilance, and she's going to take us through a session on adverse events following immunization. Karibu Daktari.
Thank you. I hope I'm audible. You can confirm? Dr. Karume?
Yes, yes, you are. Yes, you are, Daktari.
Okay, thank you. And also thank you to the ECHO team for providing this platform where we can be able to learn from each other and even also pose concerns that we are seeing in our facilities, and in the hope that we can get some feedback from others and they can be able to help us to even improve and just be able to grow together and learn together. So I'm just going to highlight issues that regarding the adverse events following immunization. Our team today is basically focused on whether we should have any concerns vaccinating individuals with comorbidities. So we move to the slide. I think it's important to start by just highlighting what is vaccine pharmacovigilance. These are whole science that revolves around detecting, assessing, understanding, and communicating the adverse events following immunizations or other immunization-related issues. We know it's important to follow this up because when you are immunizing an individual, that's a person who we perceive is not well, and therefore if we are not following to find out what events that are occurring, chances are we are going to have the reduction in confidence in our immunization programs. And with the scenario of COVID, we realize it's important that our public has confidence in the immunization program. So as we move ahead, just do a brief reminder on the various adverse events following immunization by classification. There are 5 main events. They can either be related to the product, that's the vaccine product related. They can be related to the quality of the vaccine. It can be an immunization error related, probably the handler used the wrong diluent or injected at the wrong site. It could also be an immunization anxiety related. In the vaccine center in Kenyatta, we've noted that a few individuals after vaccination, they leave a little panicked and scared, and you start wondering, will I start having thrombolytic events? So we've noted there are a few cases of those who suffer from anxiety after the vaccination or even as they're waiting for vaccination. And these are events we need to be able to document. And then there's a coincidental event that a lot of time we keep finding people are reporting social media, but now we need to be able to note what could that event actually have been caused by the vaccine. So if we move forward. So what we had already known with regards to the AstraZeneca vaccine is that there are those adverse reactions which we expect that will be common, happening in 10% of the population, that's about 1 in 10. And there are those, like as what is highlighted, the headache, the nausea and pyrexia, and I'll show you the table that has been reported commonly in our center. And then there are the other uncommon ones, which occur in less than 1 in 1,000, of decreased appetite, abdominal pain, pruritus. And again, as we go on, I'll share one event that is also uncommon, but we need to be able to report and see the frequency. So who are the people we have vaccinated? Just as the introduction, that is the age distribution. Majority of those we have vaccinated lie between the 31 to 50 age group. And this is important because when we are thinking of the issues of comorbidities, from that age group, you start thinking of potential comorbidities that will be able to be affecting them. So which are those who have vaccinated, what are the pre-existing conditions that they have had? Majority of our clients have hypertension, Then we have the asthmatics. So I have the numbers there. So we had 73 respondents. Now this was from those who reported having an adverse event following immunization. At the time, they were about 77 reports. So 73 of them had pre-existing conditions. And now if you see these graph spreads, we have the percentage in percentage form. What was that comprising of? And in terms of numbers, we see asthmatics were, the hypertensives were the majority, 35 of them. Then we have asthmatics, 25, we had 8 diabetes, then 17 is a whole range. People with suffer chronic migraine, GERD, they have an allergy, or irritable bowel syndrome. So the types of events experienced, we noted from what it is we from what vaccines self-reported were just what is reported basically from the product, that you suffer nausea, swelling at the site of injection, joint pain, fever, headache. And you can see what is most common is, as we go down, is the pain at site of injection, the brown bar 76. With the point you can be there, but this just highlights, and then now the others are a whole range that we've lumped them together. Maybe one person maybe complains of irregular menses, so we're not too sure, but because it happened after, we just added among the others. So we have that picture that mirrors exactly what it is we expect from the vaccine. So now here the graph is blank because we're trying to think, are these events any different from those who had comorbidities? And we find that those who had comorbidities, whether they're hypertensive, diabetic, they still complained of the same events. Whether it was headache, there was nothing different, unique. And because we wanted to give an opportunity to the National Vaccine Advisory Committee to be able to review the cases to see if there's anything unique that you can assign to those with comorbidities. But we've noted so far that there's nothing different. So in that case, we say we will not have a concern in terms of safety of the vaccination with those with comorbidities. But it will be important for all of us to feed the information so that we can be able to actually see, is there really a different picture with those with comorbidities? So if we go forward, so we have what we've been noticing are a few coincidental events that we need to be able to undertake investigations, and I'm glad sharing a platform with Dr. Maritin, so you can be able to take us through how investigation and assigning causality can be done at a later stage. But find that to expect that the adult and the elderly population with chronic diseases are likely to suffer from coincidental events, and this can be anything from probably somebody left and they're dizzy and gets hit by a bus on their way home, or we've had a few thinking that they have gotten diabetes as a result of vaccination, but it could be because we are very keen on finding out what could be wrong or what is different about me. That then you're discovering new illnesses that were previously undiagnosed. So we just keep on having the precaution in our facility that for those who come and they have acute febrile illness, or they have already confirmed COVID, or they have bleeding disorders, or they have severe illness warranting admission, then we need to have consider vaccination at a later stage. That's a precautionary measure to ensure that we don't expose them to potential harm. And also for the pregnant population, it's very important that for such the clientele, you need to be able to assess whether the vaccine will be of potential benefit as compared to the risk that the mother or the fetus can suffer. So what we want to encourage is that for us to be able to get data and be able to assign causality, we want to encourage that all healthcare workers need to be able to report the adverse events, and it doesn't matter whether you consider it serious or a usual event, a normal event. We need to be able to report all of them so that we can be able to identify signals and events, especially in this case where we have the newly introduced COVID vaccine. And this slide just highlights now what events, which is basically all events, events which cause parental or community concern. So any event that follows the administration of vaccination needs to be reported. And And how do you respond when a patient comes back to report an adverse event? Then it's important that you first manage the patient, reassure them, and then be able to report this event, and then given there the contact of how you can go about reporting. You can either report directly to the health facility, and the health worker needs to be able to document and upload this event to we have the national pharmacovigilance system, which can be accessed with that site. Or if you have challenges accessing it, there's a number you can call, and an officer will be able to guide you on the process. So again, just to encourage that, let's use the official channels for being able to communicate. And that we are encouraging the online reporting with the portal, and both healthcare workers and even the patients or the caregivers can be able to report the same. So now, and recently, to Lord the Thomas and Poison Board, being able to at least be active and reach out to the general population and give options of how you can go about reporting, because as I said, as it is from the events that we've reported, there's nothing unique about the comorbidity, the population with comorbidities in terms of do they suffer any unique events different from the others. They are suffering the same events as what is even expected in the summary of product characteristics. But now what comes, we say now events which relate to, which have parental community concern. Now we have some coincidental events, and we want to encourage those who have reported or have noted that either there is a change in menses or heavier bleeding, that could be a coincidental event, but it is important so that it can be well assessed and the causality can be assigned, that we can go ahead and report using the channels that have been listed. And now we go through this cycle. When you note an event, we say that is an FE detection. You need to notify the health facility or a healthcare provider, or you can go ahead and directly report, and then allow an opportunity for investigation to be carried out and analysis, and so that you can be able to assign causality. And now it is hoped that after causality is assigned, that this feedback can come back to the public, and you can be able to know that what information can we give the public with regards to what precautionary measures do we need to take. Like if we find it is now unsafe in pregnant women, then now we need to be able to communicate that. But unless you report and you document and an investigation is allowed to be carried out, which is a bit intensive, and we want to also at that point encourage healthcare workers that when a team is going around to investigate an event, that we give enough support so that we can be able to get good data to analyze and actually assign causality. Thank you. So to hand over to my colleague.
Good afternoon, everybody. Thank you for joining the presentation. I'll just share my screen shortly. So before I start sharing the screen, there is this poll we've been carrying out, and we really wanted to understand healthcare workers' embracement of the vaccine. And the poll is currently displayed. So you'll take time, you'll have the poll on your devices. Please answer the three questions. We want to know whether you've received the COVID-19 vaccinations. It's a multiple choice. We have two options. The second one is, do you plan to receive COVID-19 vaccination? Again, and as a recipient or potential recipient, you have concerns regarding the COVID-19 vaccination. So please answer and respond to the question. We'd like to know your opinion as I prepare to share my screen. So we can see the respondents. The tally is still going. We'll have the poll ongoing even as we continue to save on time. I'll share my presentation, make my presentation, and it's really a very short presentation, just complementing what Dr. Ayuak has talked about and building on from the webinar sessions that we've had in the past. And the main discussion today is really whether we should be hesitant or should have concerns regarding safety in vaccinating patients with comorbidities. Today is a very important session for us because we are commemorating the launch of this ECHO session. And when Dr. Masamaro was showing his photo, I could identify myself in that photo several years back when he launched the NASCOP platform, the ECHO platform in NASCOP. So this is really a memorable occasion, and we hope if you can take photographs or screenshots as we continue the presentation. So the poll is about to close, but you can, I think we can proceed on with the presentation to give a few minutes for the people who are yet to poll. So when we look at the outline for my presentation, it's a very brief presentation. We'll be looking at COVID-19 and comorbidities in Kenya to really make a sense of why we've prioritized people with comorbidities and even the healthcare workers, who are many of them in attendance in this webinar today. We look at COVID-19 vaccines and safety and focus mainly on the AstraZeneca vaccine, the Chadox AstraZeneca vaccine, which we are currently deploying. And I know as we introduce different vaccines within our country, we'll keep discussing the different vaccines. I think the Ministry of Health has highlighted that J&J vaccine will probably be available soon within Kenya. So we'll focus on that as we go along at a later date. Then we look at vaccine safety data. So this is really the vaccination delivery strategy, where we are phase 1, phase 2, and phase 3. And just to summarize, phase 1 has targeted frontline workers in different sectors, the healthcare sector, security sector, as well as even education sector, because of risk pertaining to the occupation in terms of COVID transmission and the fact that in the day-to-day occupation, these people coming are at increased risk of COVID-19 acquisition. In phase 2, where we currently have merged phase 1 and phase 2, phase 2 was to target mainly individuals at high risk of adverse outcomes following COVID-19 infection. And when we talk about adverse outcomes, we're talking of severe COVID, critical illness, and this leads to hospitalization, as well as even leading to critical care, admission, and death. So those are the people who have been included in this initial phase of rollout. Initially, they were planned to be included when we received additional doses of vaccine, but it was a good thing that they were prioritized under phase 1, and that has really improved the uptake of the vaccine. And this group of people have embraced the vaccine, and currently we know we were due for our second dose, I think, starting tomorrow, and now we have to wait an additional 1 month, which again is within the guidelines. 12 weeks interval between the first and second dose actually achieves better outcomes and efficacy. In phase 3, we are looking at individuals who are in crowded settings, who are likely to get SARS-CoV-2 infection by virtue of living in the crowded environment. And these have not yet been included in phase 1 and the phase 2 rollout that is currently being implemented. So in phase 3, we are looking at people in prisons, street families, sort of destitute populations that live by virtue of their economic status in crowded setting. But even within that phase again, individuals working in other economic sectors that are important in terms of providing frontline services that would result in economic turnaround, so to speak, following the multiple interruptions that have occurred within the economic sector as a result of the lockdown. So this slide is data that we have published in MedArchive, and the publication is there, the reference is there. And in this data, we really wanted to understand among the first patients that had COVID-19 and were managed in different hospital settings, what was the contribution of comorbidities in terms of poor outcomes, and basically what were the outcomes of the patients. So in our data set, we had 787 COVID-19 patients. The mean age was 43 years, 64% were males, and 58% presented with symptomatic illness. So we were collecting this data among our public hospitals and a few private hospitals within Nairobi, and most of the data was contributed largely within Nairobi and Mombasa. And 43% of the patients presented with comorbidities, and these comorbidities were cardiovascular disease in 17%, diabetes in 15%, and HIV in 7% of the patients. 11% of our patients were admitted to ICU with a mean day duration of admission of about 11 days. 7% had to be ventilated for a mean duration of 10 days. And we know even in good settings, the outcomes of patients who go through mechanical ventilations have been poor. So a lot of our patients who went on to ventilation lost their lives. And 14% of the patients eventually died. So when we analyze the risk of death in our population, we found that having an advanced age of more than 60 years provided a 1.5 times hazard ratio of death. Having comorbidities, again, doubled that risk to 2.34. And being male had a hazard ratio of about 1.76. So being male, being of age above 60 and having comorbidities were the risk factors for death. And we have seen this data. It had already been seen globally, and we were able to demonstrate it even locally. And that's why this group of people have been prioritized initially under phase 2, but now phase 1 and phase 2 are merged together. And therefore, these are the people who actually require vaccination to prevent or to avert a poor outcome. This doesn't show very clearly, but it's really looking at the different hazard ratio, which I've already talked about. And we can see age above 60 compared to a reference age of 60 and below, which is where I'm trying to put the cursor. And then having a chronic illness, again, increased that risk significantly to twice 2.34. And then being of male gender, again, was related. The clinical symptoms was important, but again, we know that people who have comorbidities or advanced age or these similar risk factors, the male gender, are likely to progress their illness from mild symptoms to severe and critical. So having clinical symptoms, again, contributed a bit, but already it was demonstrated for the specific risk factors. So this is data from the situation report, cumulative data from the CITREP that was compiled yesterday. So it provides cumulative data of the total caseload in Kenya, the COVID caseload. And in this one, you can see where most of the infections are, and we can see the contribution of people who have older age. And I'll share with you in the next slide. We can see the contribution of the people of age 60 years and above seems relatively small. In this curve, we are looking at the adult population. So adults starting from 20 years going ahead. So although they seem to be the smallest bracket in terms of infection, they are the people who we lose. And when you hear the deaths announced on a daily basis, the largest contributor is actually people who are older than 60 years. And another important thing to note, a lot of people, as we age, most of these comorbidities also occur in older people, but we also know there are younger people who have hypertension or diabetes. But older people are disadvantaged because most often they'll have essential hypertension, they'll have other comorbidities, and these are really non-modifiable risk factors that eventually contribute to mortality. So in this slide, this is really the mortality data, cumulative mortality data, and we can see we've lost patients across the different age groups, but most of the patients that we've actually lost, more than half of the patients that we've lost are in the age group 50 and above years. So having an older age group, having comorbidities, again, contributes to increasing the magnitude of the people that we've lost. So if you're to look at this graph and really try to look at an addition of vaccines as an intervention to alter the course of the illness, it makes a lot of sense to vaccinate. And if you're in that age group and listening on this call today and you've not received your vaccine, then it means you really have to adhere to the other non-pharmaceutical interventions, and therefore you have limited your options in terms of averting the poor outcomes that we've already talked about. We have also done this study, led by Dr. Baraza, looking at the unit cost of COVID-19 management in Kenya. And why I'm talking about this, when you're looking at an individual level, when you talk about mortality, it's really important. But we know in the recent past, when we've had the third wave, a lot of families have called and really struggled to get beds and facilities for admission of patients, their family members who are infected with COVID-19. We've seen the crisis in India, and particularly for COVID-19. Initially in the pandemic, I think many patients were taken care of by the government, but increasingly families are having to meet the cost of this care of patients, and therefore prevention is really, really important. So in this study, we wanted to really calculate the cost of managing patients with COVID-19, and I'll try to position the cursor on this last column. These are patients who have critical COVID-19. So we have different costs for patients with moderate illness, severe illness. We didn't, the cost for asymptomatic illness was negligible because it was mainly related to personal protective equipment. And we know that when we rolled out the home-based guidelines, a lot of patients with mild illness or asymptomatic illness are being nursed at home. So the cost drivers are patients who have to be admitted in hospital and spend several days in hospital. So from this study, we found the daily cost of managing a patient in the ICU setting is about 60,000 per day. And this study was done in public facilities. We're not talking about private facilities. And we know in private facilities, the cost is really out of reach. So looking at it in terms of, if you're presented with a vaccine that can prevent you from progressing to severe illness or going through the entire risk and getting COVID-19, if you have risk factors, you go on to develop severe illness or critical illness, you're likely to be hospitalized. And this is the financial implication for your family. This cost was very conservative because it was calculated based on an estimate of the previous data that we had shown, where we just estimated 10-day admission within the ICU. So again, a lot of patients are on ventilators for much longer, and some patients require dialysis, among other treatment modalities, and those really move the cost of care significantly. So if we have a preventive strategy that can really avert some of this cost, then it makes a lot of sense to accept that intervention as a preventive strategy. So this slide really emphasizes the COVID-19 vaccine endpoints. And when we are talking about the COVID vaccine, we have different points where you would want to intervene. The first intervention would be if you had a vaccine that could prevent infection, it means it blocks SARS-CoV-2 from infecting the person who's exposed to the virus. And therefore, if you block that, the person will not develop any symptoms. They will not enter the pathway of the natural history of COVID-19. We know that when patients get infected, they progress from asymptomatic disease, and their symptoms can progress on to moderate, severe, and eventually critical illness. And when they have severe symptoms, symptoms of critical illness, they require to be hospitalized. And depending on severity of illness, some may require intensive care admission, to be admitted in the ICU. And in the ICU, some patients recover. We've lost a lot of patients from that. So that's really the pathway. So at the areas where we have the red X's, it's really looking at different vaccines, different vaccine candidates, and what that intervention in terms of the points where they're likely to make an impact, and what would that mean. So for SARS-CoV-2, we know that in some patients, the current vaccines that we have, some may not really prevent infection, but they may prevent progression of illness. So despite the fact that you may be infected, you may not progress on to severe illness. You may modify the course of the illness so that you just develop mild symptoms without necessarily progressing to severe illness. And that's really the goal of any vaccine. If you're looking at if you have that choice between the vaccine that will prevent infection or the vaccine that will modify the course of the infection. So the best vaccine would definitely be the one that prevents infection, what we call sterilizing vaccines, because it means we can really eradicate, so to speak, SARS-CoV-2 infection. But so far, most of the candidates that we know, most of them really prevent admission. All of them have 100% efficacy in terms of preventing severe forms of the disease, in terms of illness, severity, hospitalization, and admission to ICU, and therefore having an impact in preventing death. So this slide is just to remind us about what is in the vaccine, and we already know what is in the vaccine. We have different components, the active ingredients, we have adjuvants, we have residual trace of some of the chemicals that are used in terms of deactivating the vaccine, depending on the construct of the vaccine. Some vaccines have preservatives and stabilizers to enhance their life, and then water for injection as main ingredient. So this is just a general slide showing the different components of vaccine. But for the SARS-CoV-2, the Chadox vaccine, you may not necessarily have all these particular components. So when vaccines are designed, they have to go through clinical trials, and they go through different phases, phase 1, phase 2, and phase 3, and then submission to the regulatory authorities when you have a lot of data, where you now get market approval. So for the vaccines we are currently using for COVID-19, none of them has reached the stage of market approval, but they are used under emergency use authorization, which is a regulatory framework that allows vaccines that have passed or have generated a lot of safety data and efficacy data to be deployed in the setting of a pandemic like we are in now, to be able to be used to mitigate the effects of the pandemic. So the vaccines that we have been added to our armamentarium, which is the hand hygiene, face masking, socially distanced, and then on top of that, now we have vaccines. And vaccines are useful because they do not rely on our biological or behavior. They're not behavioral interventions, because we have to remind ourselves daily to wear masks, to wash our hands, to socially distance. But once you have the vaccine and everyone is vaccinated, then a time will come when we say, then we are safe enough to abandon a lot of those behavioral interventions. But until a certain threshold of people are vaccinated, we still have to combine them with a non-pharmaceutical intervention. So when you look at clinical trials, this slide is important because it tells us the different phases. In phase 3, you're looking at efficacy and additional safety, and you're looking at a lot of people. And because the clinical trials are time-bound, sometimes some safety events may not be noticed within clinical trials, either because of the numbers that are enrolled and events that were more rare, or also because some adverse events may have a long-term effect and take multiple years to identify it. So understanding the different phases of clinical trials help us to put it into perspective where we are with the COVID vaccines. And even when you're looking at the safety data, it helps us to understand when we're not able to see some events that were not seen in clinical trials, but might now be seen as we use the vaccines under emergency use approval. And a case in point is what we've heard about the clots in Europe, and I'll discuss that as we go along. So this is just a slide highlighting the different vaccines that I'm not even talking about, but to tell us for the AstraZeneca, in the clinical trials, multiple clinical trials in different parts of the world enrolled more than 50,000 people. And therefore, even when you're looking at the data that Dr. Edward has shared, a lot of that data had already been derived from clinical trials. So in this slide, we are looking at what she has already talked about. So I'll not spend too much time about it, just to explain some of the adverse events following immunization may not have been identified in clinical trials, But as we deploy the vaccines, we look out for what are called signals. So signals are events that are noted in different parts of the world at different time points that are serious enough to warrant additional investigation. And the clots include some of those because they were not identified in the earlier clinical trials, but now have been noted in the European region, in the Canadian territory where they're also using AstraZeneca vaccine. So we'll keep that in mind and I'll revisit it as we go along. And she's also talked about the various classifications of the adverse events following immunization, so I'll not overemphasize that. But just to tell us, because I know there may be some of you listening to this presentation for the first time, though I've used these slides in earlier presentations, so just bear with me. When you're talking about the adverse events, we normally classify them into minor reactions and severe reactions. This is sort of a clinical definition, and I'll talk about the regulatory definition in the next slide. So when you're talking about the minor reactions, and Dr. Ayuak shared some of the minor reactions that have been reported through the database. These are adverse events that are predictable. They've already been identified in clinical trials. They're expected because of that's how the vaccines induce the immune response. And many of them just require reassurance of the person who's reporting them, because some of them sort of go away without a lot of intervention. For example, pain at the injection site, swelling at the injection site, redness, and then the systemic side effects like fever, malaise, muscle pain, headache, or loss of appetite. So normally these disappear within 3 days. If they persist, then that's a cause for concern. And those are the ones that are investigated further. And if a person requires to be hospitalized because of that, then those are serious enough. And I'll talk about that in this slide. So, sorry, my slides are misbehaving, sorry. Yeah, so this is just to highlight those symptoms that I was talking about that are expected. So when you give the vaccine, when you inject the vaccine, you want it to induce an immune response at the point where you introduce it, and this immune response is transmitted systemically through various mechanisms, and eventually you have antibody production and cell-mediated immune responses. So initially you have local symptoms, and some of the cytokines that are produced in that local place are carried through the bloodstream and eventually are responsible for the systemic symptoms such as headache, fever, and fatigue. So when you receive the vaccine, do not be surprised. These are expected, these are predicted, because that's what the vaccines are supposed to do. On this other side, it's still explaining the same mechanism, but just highlighting how the different response varies based on the route that is being used. So for example, the neural route, the pain receptors at the site are able to transmit the response directly to the brain, to the pain centers in the brain, and you feel the pain fairly much faster compared to some of the response that require the humoral response that are transmitted through the bloodstream to the liver, where now additional cytokines and acute phase reactants are produced. And this leads now to the systemic side effects. So some of the events occur immediately a few hours after injection, but some may take a few days, 2 to 3 days, and some of these would remit on their own. So having talked about the different reactions, we have what is called the serious reaction, which in the clinical trials, the DSMB would be, the Data and Safety Monitoring Board would be looking out for this and carrying out additional recommendations based on what they've attributed the adverse events to. And these are adverse events that result in death, inpatient hospitalization, persistent or significant disability, are life-threatening, or result in congenital malformation. That's an additional one. When pregnant women are included, then you have to include congenital malformation. But aside from that, we have additional additional adverse events that would warrant interventions. For example, if they occur in a cluster, and in a cluster, you're talking about maybe a specific facility where people were vaccinated, they all develop a certain symptom, then you'd need to investigate that. And then the other thing is if there's a concern to the community, for example, concern to the parent or concern to the individual, then you have to investigate to do a little bit more of that. And these are the ones that have to be reported, and investigations have to be conducted, and causality assessment has to be done to see if they are related to the vaccine or not really related to the vaccine. This slide just highlights the commonality, or whether the reactions are very common, uncommon, rare, and very rare. So as we speak now, the clots and the blood clot syndrome that's attributed to the AstraZeneca vaccine is currently, based on the percentage that's calculated, it's when you calculate, at the time when the reports were reported to the European Medicines Agency, there were 222 cases out of 25 million vaccines given. So when you calculate that, it's 0.0008. So it's very rare. So looking at that proportion, you'd call that a signal and would warrant additional really heightened surveillance to be able to identify in different jurisdictions. And once the causality assessment is done, to see in which of the 5 areas of vaccine reactions you would actually classify that under, because it may be vaccine product related or vaccine quality related. At the moment, it's not really very clear what it is, but because the same clots have been described also for the J&J vaccine, it may just be related to the vector, maybe the adenovirus vector, but at this moment in time, we do not know exactly what explains the clots. And another thing is that when an event is very rare, then it's again difficult to say it's vaccine product, because it may be vaccine product in susceptible hosts. So you're looking at individual predisposition to that event. So at this point in time, it is considered a signal, and we don't know in which of the classification it may eventually fall, because we need the additional data regarding that. In this slide, this was just to highlight, in most of the vaccines, they have additional excipients as underlined in red on the last column. And for the RNA vaccines, they use polyethylene glycol, and this has been associated with anaphylactic reactions. But again, the anaphylactic reactions have been very rare. In the adenovirus vaccines, we have polysorbate 80 as a preservative. And again, all of them have that common, like the adenovirus vaccines and the protein subunit vaccines all share the polysorbate 80. But for now, we haven't attributed any adverse event to the polysorbate 80. So this slide, I think, has come a bit too late, but we're looking at the Chadox vaccine just to explain to us how the vaccines work for those who are on this webinar for the first time. So when you're looking at the Chadox vaccine, it's basically using a vector, which is a chimpanzee adenovirus that's modified, and the modification is that it's replication deficient. It doesn't multiply in the body. It's unable to cause disease. But what it does, it acts like a vehicle where it's carrying the spike protein genetic sequence, which is inserted into the vector. And basically, that's the vaccine construct. So when you're injected with the vaccine, the cells, your immune cells will express the spike protein, and the body produces antibodies against the spike proteins that have been expressed by the cells. And as a result of those antibodies, when you are infected with SARS-CoV-2, the immune system is able to attack the SARS-CoV-2. So it provides that defense to the body by preventing you from getting the full effects of the infection. So what we currently know is that for the AstraZeneca vaccine, it may not necessarily prevent infection, but it modifies the cause of that infections and prevents severe illness and critical illness. Dr. Ayuak had this slide, but in this slide, it's just to tell us the proportions of, when you talk of very common side effects, that means they occur in 1 in 10 people. In this room where I'm seated, we are only 4 of us, but if you are 10 of us, 1 of us would have these side effects like headache, fatigue, pain at injection site. So it's very common. when you're talking about the just common ones, that they occur in 1 in 100 people, and in this category we have the vomiting. And then uncommon is 1 in 1,000 people, and this include lymphadenopathy, dizziness, abdominal pain, excessive sweating, itchiness, and rash. So that's just the category of what we've seen. And from the report she shared, the categories just highlight what was seen in clinical trials. The anaphylaxis is what is the worst. It's something as a vaccinating center you always have to prepare because you don't know the host predisposition. And although we've said we haven't seen it with AstraZeneca, the facilities have to be prepared to be able to manage and respond to the anaphylactic reaction. So this is a safety net, which gives us comfort that if someone is injected and they are predisposed to anaphylaxis, they will be managed, because in part of the training, vaccination centers were required to prepare for anaphylaxis, which is an emergency, a medical emergency. So it's rare, it's potentially fatal if you don't act fast, and it occurs a few minutes to 1 hour after receiving the vaccination dose. And that's why the facilities have to be prepared. And if someone is injected and they develop difficulty in breathing, swelling of the face, tachycardia, rash over the body, dizziness and weakness, they have to be, you have to suspect an anaphylaxis and act fairly fast. And in the training material, this is included. And even for those of us who've already been vaccinated, we had to wait 15 to 30 minutes after vaccination within the facility, because you can still have anaphylaxis after that time. So this provides us a safety net that if you are in a facility and you're predisposed, again, this is taken care of. And for people who have anaphylaxis, who had anaphylaxis to a first dose, they cannot receive a second dose. So looking at the efficacy data, again, this is from the AstraZeneca. I borrowed this slide from clinical care options. And looking at the AstraZeneca vaccine, which you've used, we are still rolling out. Again, the efficacy in the clinical trial was 62% for the 2 doses when they're given 1 month apart. We currently know that if you space the 2 doses fairly far apart, like 12 weeks, you get a higher efficacy. So the only balance is that in that interim period, people feel that they may be exposed because of they just have 1 dose of vaccine in their body. In this slide, we're just looking at local events. This is from the clinical trials, and we've already sort of highlighted about this. And this is the local events. So pain at injection site, tenderness, warmth, and you can see it was in the different age groups. 18 to 55 years, pain and tenderness were the most common. And even in the slightly older 56 to 69 years, again, pain and tenderness at the injection site, and even in the older population. So pain and injection site was the commonest across the different age group. And this was the first dose within 7 days after the first dose. The first dose is called the prime. The second dose is the boost. When we look at the systemic side effects, they were far much more common, particularly in the age group 18 to 55 years, followed by 56 to 69 years. The people who are older than 70, surprisingly, had fewer side effects. It may just be a factor of maybe they have other comorbidities that maybe blunt the effect, but also we know that in older people, because of immunosenescence, some of the immune responses may be reduced. And some of these, like I showed you in the previous slide, for your systemic effects, they're mediated through the humoral system. So they may be delayed or dampened because of aging of the immune system. When you look at the safety again from the boost, 7 days after, for the younger age group, actually across the 3 age groups, they were more or less similar. So fatigue, malaise, muscle ache across the 3 age groups, but again, far much fewer events in the older age group above 70 years. So I added this slide when Dr. Ayuak was talking about what we do in the National Vaccine Safety Committee. So in the committee, we adjudicate. Our mandate is really to adjudicate, to provide advice to MOH. So within that structure, we have PPB and the vaccine program, who who formed the Secretariat for the National Vaccine Advisory Safety Group. But our main role is really to adjudicate causality. So using a standardized approach, when all the investigations have been done, to try and see how we can classify the adverse events following immunization. So this is just a summary of what happens when someone has an adverse event following immunization and what should be done. So for events that are serious, and I've talked about this, that result in death, hospitalization, significant disability, are life-threatening, or result in congenital abnormality or birth defect, or are part of a cluster, or are part of a signal. All these warrant investigation. And part of investigation is that you visit the facility and you want to find out more information about the person who was vaccinated, the vaccine they received, and the clinical progression of the illness that they developed following the vaccination up to the time when you're doing the investigation, and what additional tests have been done. So this is really where I'm appealing to many of you who are listening to this audience and work in facilities, that part of the investigation is that when a person develops a serious event, they come to the hospital, you have to manage them as per the standard of care, look after them, and at the time, report the event so that this can actually trigger the events for investigation. The initial steps are to identify and rule out immunization program error related adverse events, immunization stress events, and coincidental events, so that the only two that are left are vaccine product, which is type 1, and vaccine quality, which is type 2. So you want to really rule out these ones, which are easier to do, because you note whether there was several events given at a specific time reported from that facility, what you are calling the cluster. The third step is if the district authorities and experts feel the adverse event, the IF investigation can be done locally, they can visit the patient and locality and initiate the detailed investigation. So the investigation is very detailed and thorough, collecting a lot of information about the event. Sometimes we may have experts coming from another place to help with this investigation. So when you're talking about experts from another place, in the setting of our country, because these are slides that we use at the regional level, I've borrowed them from a WHO training that we had. So when you're talking about experts, in the case of our country, we are talking about people coming from maybe the national level to support counties in terms of investigating the adverse events following immunization. So we are not talking of international people coming, but we're talking about people coming from national level, coming to counties to support the investigation of that. For death, national investigation should be led by a team from the National Committee, supported by the EPI program and the PPB, for example, in this case, and other experts. So when a death occurs, this is really what should happen, and this has to be done fairly soon, because when you have reported deaths, like when we had the deaths in Europe because of the clots, it really caused a lot of concerns, and this can actually affect vaccine acceptance and result in hesitancy. And then in terms of tools and resources, we have a lot of tools and resources that really support us in the work that we do. Even the process of causality assessment is a very transparent process where we have a lot of tools that really support process. This is just illustrating the sequence of events that we follow through following any of the adverse events following immunization. And this is really my last slide. Thank you very much.
Thank you, Dr. Mary Tim, for giving such a concise and brief presentation on the vaccine. In the interest of time, maybe just to summarize, we've had a lot of questions regarding comorbidities, a lot of concern, and that's mainly the reason why we have this session today. What do you think about comorbidities? Can somebody take, because a lot of people want to know that, if I have diabetes, if I have hypertension, if I have asthma, if I have osteoarthritis, I'm on medications, can I take the vaccine? Yes or no?
the vaccine, and really I showed the data, the vaccine protects that group because that's the group that's vulnerable in terms of developing severe illness following infection. And from the vaccine that we're currently deploying, the safety concerns in terms of doing harm are minimal because of what we've already seen in clinical trials and what we are also collecting as we deploy the vaccine. So looking at the risk of getting COVID and having a poor outcome, the risk is much higher of dying if not taking the vaccine. And therefore, I'd advise such a person to take the vaccine. The vaccine is not contraindicated because of other medications that they may be taking. There's no potential drug-drug interactions on the other medications that people may be taking. And therefore, I'd advise such people to take the vaccine. If they are younger than 60 years, I know in my lecture I focus on 60 years and above. If you're a young person with comorbidity, you should still take the vaccine.
Thank you very much, Dr. Ari. Yes, Dr. Iwa?
Just to support that, when we look at the proportion of reports, those who had comorbidities, about 25% of those who report. So if we had those who are having adverse effects having a bigger proportion of those reports, like if we have 25, if there were 75, I would say there would be a concern, but they form 25% of the population which has reported. So I would not, from that, I would not say that they are at higher risk.
Yes. Thank you. It's a very commonly, frequently asked question, and it's good we make sure that every person in this webinar is aware about that fact. I loved how you addressed the clotting. It's a very rare phenomena. A lot of people are also asking about that. Just for the interest of the users, MOH has opened up a platform for every person. So you can go to, I have written it on the chat box. You can go to the portal.health.go.ke, sign up so that you can be able to see when your next dose is, get your certificate, and hopefully very soon they're going to open up the adverse effects so that you can self-report and we can have the data collection as a mass. Another commonly question is breastfeeding and pregnant women. I feel like if we do not address that in this forum right now, it would be a missed chance. What are your take on breastfeeding and pregnant women on taking the vaccine? Dr. Mary Tim.
So from the clinical trial, yeah, none of the clinical enrolled pregnant women as part of the study subjects. Some of the vaccine being deployed in different settings have opened up pregnancy registries. Some are actually actively recruiting pregnant women, like I know the Moderna vaccine, they are currently undertaking studies on pregnant women. Looking at the vaccine and their design and what we know about the vehicle and the spike gene, none of the vaccines really, none of them that you're currently using in our setting is life attenuated, because you always, life attenuated vaccines are contraindicated in pregnancy because of the potential to revert to virulence and cause disease in the vaccinee. So for the AstraZeneca vaccine, it doesn't have that potential of reverting to virulence. So as it is, and understanding what we know about the vaccines, they are fairly safe. They are safe in use in pregnancy, but with a caution. Then the caution is that when you're looking at balancing risk versus benefit, because we don't have long-term safety data for these vaccines we are currently deploying, and we are really monitoring the people who have received. And therefore, you have to individualize the decision whether to vaccinate a breastfeeding mother or for a lactating mother as well, but more so for the breastfeeding mother because of the potential effects on the baby. And when you're talking about balancing the risk versus the benefit, so an example, when you have a frontline healthcare worker who's female, who's pregnant, the fact that they're in the front line puts them at really increased risk of getting infected in their line of duty. And therefore, the vaccine would be of more benefit. The benefit of vaccine is definitely much higher than the potential harm by the vaccine. The other caveat is that even when you're a physician, you want to look at the trimester. So we don't have a lot of data, especially in the first trimester, in terms of the effects of the vaccine. And therefore, if someone is in the first trimester, you may want to postpone the vaccination until they are away from the first trimester, because we know for most of the teratogens that we have, the first trimester is the most crucial period, because that's when the organs are forming. And therefore, you might want to defer that vaccination until they are away from the first trimester.
Yeah, and I think it would be important to also ask people when is their last menstrual period, just in case. Thank you very much for today's sessions, Dr. Bruce and team. Thank you very much for the ECHO program. I love telemedicine. We hope we have a continued partnership with the ECHO project. For the people who have reached out, I think you can also reach out to Dr. Kinuthia via knhresearch@gmail.com. For the people who are asking questions on hesitancy of the vaccine, we have partnered also with Viral Fact Africa. It's available on most social media platforms. If you just Google Viral Fact Africa, you will get a lot of content that will disseminate and demystify a lot of the questions that people are addressing. Thank you very much for the audience. Dr. Do you have some? Yes.
So the poll results are being displayed. I hope you can see. We'll share them so that you can, we are sharing the screen for the poll results. And I've seen Bruce has asked about the results of the poll. So we'll just announce. So the first question was, have you received COVID-19 vaccine? 60% of our audience have received, 40% of our audience have not received the COVID-19 vaccine. So we have to do more to make sure we move the numbers from 60% to 100%. The second question was, do you plan to receive COVID-19 vaccination? And this is encouraging. So maybe the 40% are included in this, because 89% of our audience today actually say they plan to receive the COVID-19 vaccine. Only 11% say they do not plan to receive the vaccine. And the third question was, as a recipient or potential recipient, do you have concerns regarding COVID-19 vaccine? And the poll again is 58% for yes and 43% for no. So thank you. I think with the platform now that we have, we want to move those numbers for the third question to address the concerns that our audience, who are mainly healthcare workers, have regarding the vaccine, so that we can actually move the numbers to no, polling at 100%. So we'll use this platform very well to meet you at your point of needs and address the concerns that you have, and we'll continue having vaccine-related webinars to address that. It's very encouraging that many of the people who haven't received are planning to receive, because it may just be a shortage of vaccine, maybe where they are found. So again, thank you for taking part in the poll today.
Thank you. Dr. Karingo?
Thank you, everyone. We really want to thank our participants for staying with us till now. And we are now coming to an end. But let's invite Dr. Masamaro to just give your last comments and appreciate the team. And after that, Honorable Bai, if you can just close it up for us. Thank you.
Right. So once again, want to really first thank the presenters, Dr. Maritim and Dr. Yuak, for the excellent presentation. I want to thank the audience for the good engagement, especially in the Q&A. I really want to thank our stakeholders, everybody who has participated in making this a success. Going forward, we will, hopefully expand into the rest of the counties, but also use this platform to engage even more, especially in this COVID-19 season. So on behalf of myself and others and CDC Kenya, I really just want to appreciate and thank everybody. Back to you.
Thank you very much. We'd also like to have a last word from Honorable Joseph Mbai. Karibu.
Thank you very much, team. I must say that this has been a very wonderful discussion, very informative, and also an eye-opener. And I want to thank all the partners, CDC, JPEGO, and the rest, for actually putting this forward to the counties so that you can improve the way we manage our patients, to improve the quality of care, and to reduce the turnaround time that our patients can get treated. It is long overdue because we've been doing CMEs, yes, but sometimes because of lack of consultants, we may not be able to make sure that we have reached everyone. But with this kind of support through video conferencing, through Zoom, we'll be able to reach as many as possible, and we can be able, even as leaders in health, to make decisions timely and to improve the outcomes and the indicators that are always down. And I must say that on behalf of Dr. Murega from Kiambu, is the one who was supposed to give the closing remarks. I must say that for us in the counties, we are very delighted and we really appreciate that support. And I hope that we'll continue engaging and make sure that we make this happen. One of the things I always like telling people is that a strategy is very good, but if it is not implemented, then it's just a waste. And we can dedicate ourselves to do this on a daily basis and to make sure that it happens in the counties. Thank you very much, team, and God bless you all. Over to you, Chair.
Thank you very much, Honorable. Thank you very much, members. We've now come to the end of this session. Indeed, with this kind of collaboration and teamwork and innovativeness, we'll be able to move far in matters of healthcare. So thank you very much. Goodbye to all.
Oh, it's okay. I think a few of them I'd like to see. There are some who had asked questions regarding breastfeeding. Thank you, team. Thank you.